So we'll continue. Okay, so we'll continue where we left off. Is this your case?
It was Robert's.
Yeah.
Robert,
Yeah,
this is
I
your
think it's me.
Robert? Okay, go for
Yeah.
it, Robert.
So there's a lot of edema in the talus and navicular bone with a lot of degenerative change and across the articulation and
Right.
joint diffusion.
And marked loss of the arch. So you have severe pes planus here in this particular case. Go to the axial images. What do you see here?
Looks like there's either an erosion or I guess osteochondral defect.
Yeah, so that's an erosion. This is another patient with rheumatoid arthritis who, and then with one of the things with rheumatoid arthritis, you can destroy the joints, but you can also destroy the ligaments around joints due to the inflammatory change and get instability, both of the foot and ankle as well as the other joints. Again, this is something that used to be very common that we're hoping we won't see going forward so much.
Moderate to large ankle effusion. This looks kind of complex. There's some
Right.
debris in there. And the
So it's probably mostly synovial thickening then, or something to do with debris, not just an effusion, right?
yeah.
Okay, coronal T1 on this low field scanner. And here we can see, again, more synovial thickening, possible effusion. Here are the axial images.
Yeah.
We can see all this thickening. And again, this is not uniform like fluid. This was all synovial thickening, and this was synovitis and rheumatoid arthritis.
Okay, so here looking at the talonavicular joint, looks like there's some erosive change in that talus, joint effusion, edema in the sinus tarsi. Yeah, erosive change in that subtalar joint as well.
Here are the coronal images. You know, kind of
Basically,
joint disease here, as well as all this inflammatory tissue within the sinus tarsi. Looks like sinus tarsi syndrome. And if you remember when we talked about sinus tarsi syndrome, there are a number of different etiologies. Probably the most common is traumatic injury to the interosseous or cervical ligaments, leading to chronic instability of the subtalar joints. But another one that used to be much more common in the older days was rheumatoid arthritis.
do you think that tibio-talar joint is also involved, John?
There's another case. And in severe situations, you can go on to marked instability, marked destructive disease, and this is more end-stage rheumatoid arthritis. Look how unstable here. Here's the calcaneus, there's the talus. So you have dislocation, chronic dislocation. Again, with a lot of destruction of bone and ligaments, you can get a marked instability in rheumatoid arthritis. So again, hopefully we won't be seeing this. Another example of the severe destructive disease, especially these weight-bearing joints, of the subtalar joint with rheumatoid arthritis. Okay. Robert.
All right. Looking at the forefoot here. Looks like
Oh no.
proximal phalanxes.
Robert?
Can you hear me?
God.
I can hear you.
I think
We know what to do. Right.
Yeah, I could hear you too, Dr. Dragutis.
Thank you.
Click into WebEx again.
I don't see that.
Maybe.
Let me do this. No. So can you guys hear us?
Yes, we can hear you.
Robert? John?
Can you hear me?
Into WebEx settings.
I can hear you.
what I was going to ask is which sorry, tarsophalangeal joint is involved.
I can hear you guys now. This
Okay.
is very weird. I don't know why it's switching my speakers to the microphone, and when it does that, we can't hear you. Very weird,
It's known as modern technology, John.
I guess. Oh, my son just told me that at Google now, AI is defined as software that's not yet working. And AI that's working is just called normal software. So, what do you think of this case, Robert?
Well, here I saw the answer there. It looks like there's a dislocation of that proximal phalanx relative to the metatarsal head.
Okay.
Which one?
It's a good question.
Yeah.
So, yeah, I don't know
So,
maybe the fifth.
so you can get, as we've been saying, involvement of the ligaments and tendons without bony erosive disease, and you can get marked instability and dislocations, especially the weight-bearing joints in rheumatoid arthritis.
And the reason I asked is because the first ray, the first metatarsal phalangeal joint, and the first helix only has one joint. So that's the way you distinguish the first and second toes.
Mm-hmm.
Yeah. So the great toe has only one joint. Also, the great toe, you tend to have sesamoid bones, which we don't see here as well. But we don't see the rest of the toe here, so we don't see the rest of the joints.
Oh, so I guess I would say that's the second one, but
Yeah, maybe.
you'll be able to tell that better than I.
I
You
can't.
gotta go proximally a little bit.
Yeah, I can't tell on this. Okay.
One thing I haven't mentioned is when you do surgery on the foot, especially the forefoot, what you try to do is to save on the medial side. You want to save the first metatarsal as much as possible, especially when you're dealing with infectious disease and or vascular disease, i.e. like diabetes, neuropathy. And also, if you save the first, and if you can save, and you cannot save the first, but you can save the fifth and the fourth and the third, or the fifth and the fourth metatarsals, you can get a foot that you can walk on. But if you cannot save those two entities, you got problems with walking.
Thank
So
you.
you do everything you can to save those rays.
Thank you.
And it's very important to do that, even though you're sometimes may have to have a little risk involved.
Okay. Jason.
All right. Looks like the first metatarsal is dislocated medially, and there's a lot of soft tissue and periarticular erosion there. Yeah.
You can see it's dislocated here and see some erosive changes and synovial thickening. And that's a chronic metatarsal tarsal dislocation and rheumatoid arthritis.
You can save the toe in this situation. Basically, you can do a fusion. I don't think soft tissue work will save that.
Thanks, John.
Situation.
Okay.
Here, looking at the first MTP joint, looks like there's medial subluxation, maybe,
Right.
of the first
Yeah.
metatarsal head.
So you see this fairly frequently, typically in hallux valgus with degenerative disease,
Yeah.
but it could also be seen in rheumatoid arthritis.
Okay.
Robert.
All right, so here looking at the ankle. On the axial views, it looks like there's fusion of the talus and
Okay.
the lateral malleolus.
Right. And so fusions, they certainly can be congenital, but if they're acquired, it's very commonly done in rheumatoid arthritis. And when we get to, well, let's see, we had the arthritis lecture. Did I show examples of how this happens yet? We'll certainly do it again when we do the wrist. So what happens in rheumatoid arthritis that leads to these erosions is you get inflammatory disease on both sides of an area of articulation of the bone, and you develop osteitis in the bone. You destroy any soft tissues in between the two. And then when the rheumatoid arthritis the inflammatory disease starts subsiding and getting better, either from treatment or as part of the natural course of the disease, bone loves to heal. And if there's raw bone next to it, it's gonna fuse with that raw bone. And I'll show you examples where we follow this over time with MR, where you start with osteitis on both sides of an articulation, and then you can follow it over time. You can treat it with TNF-alpha inhibitors, and then you can watch the two bones fuse together. So I think that's the mechanism of how it happens in rheumatoid arthritis. So here we can see a fusion between the tibial plafon and the distal fibula. Tayson, you next?
Yeah.
Okay.
Looks like we have fusion of the talus and the calcaneus.
Yeah. And so here is a fusion of the talus and calcaneus in someone with rheumatoid arthritis. Yeah.
Okay, so here we have fusion of the navicular with the medial cuneiform.
Yeah.
Hmm.
So you get fusions basically everywhere. Here we can see more bone fusions in rheumatoid arthritis. And again, hopefully these kind of chronic changes you guys won't be seeing because these patients will be treated much earlier in the course of their disease. Robert.
Yeah. All right, so we have a 46-year-old male with a history of rheumatoid arthritis, chronic right second toe pain for 6 months following surgery to excise periarticular calcification, post-op course complicated by significant tissue ischemia and local sepsis. And so yeah, pre-op, I do see a lot of that periarticular calcification, second digit. Post-operatively, I don't see that. There's a little bit of calcification there, and then it looks like there's been partial amputation.
Yeah, probably the middle phalanx was amputated, and the distal phalanx is now staking here with the distal tuft right there. And then here we can see calcification in other areas in this particular patient. Patient also had interstitial fibrosis, other areas of soft tissue calcifications. And here we can see a lot of bone disease. Almost looks like a fracture, but that's those erosive changes. Okay. You have an idea of the diagnosis in this?
I do not.
Yeah. So when you see these kind of calcifications in someone who has symptoms of inflammatory disease, then the thing to think about really is the CREST syndrome. It stands for calcinophus Raynaud, and so this typically occurs in the distal parts of the phalanges in toes due to Raynaud's phenomenon. You get esophageal dysmotility, sclerodactyly and telangiectasia, So they basically present predominantly with scleroderma and skin changes. But when you start seeing these kind of calcifications, think about the CREST syndrome. And it has other features that you can look for with the CREST syndrome.
How would you make a diagnosis, Robert, of a condition like this?
That's a good question. I'm not entirely sure, to be honest.
Well, the skin is hard. It's almost like touching a rock.
Mhm.
And the other thing is, if we're talking about the blood flow, you put it in cold water and it becomes very painful. So Raynaud's phenomena is diagnosed by, in old days, we just would put a cold water on and put the patient's hand in it, and they become very, very uncomfortable.
Yeah, you listen to him scream.
I don't remember the name of the test, but it doesn't matter.
Yeah. Okay. Good.
And one thing that you don't do with Raynaud's is smoke.
Right. Not good for your peripheral vasculature.
I don't think smoking weed does any good either. That's becoming a real problem in America, by the way.
Okay.
All right, so it looks like at the proximal phalangeal base of the second digit, we have an erosion.
Okay.
That's some inflammatory tissue there.
So here
Adjacent to
we're
it.
kind of dealing with periphery. So it certainly looks like you've got pannus formation here and erosions. So to be concerned about an erosive disease. This is actually a bit atypical for rheumatoid arthritis, though I'd certainly think about it. Rheumatoid much more commonly involves the metatarsal heads in this location, especially the second and third. But certainly put it in that category, and you need the rest of the clinical history. But once you get distal to the metatarsophalangeal joints or metacarpophalangeal joints, it's called more peripheral disease. And what would you add to the differential if you get peripheral erosive changes? It could be erosive osteoarthritis, but that tends to involve the joints. This is really outside the joints, and the other big one
Gout?
is psoriatic arthritis.
Psoriatic. Okay.
So, yeah, whenever it's more peripheral like that, and psoriatic arthritis overlaps a lot with rheumatoid arthritis. You certainly can get the metatarsal head erosions as well, but psoriatic tends to involve more the peripheral joints. We'll talk much more about this when we talk about the hand and go into how to differentiate psoriatic from rheumatoid arthritis when we do the lectures on the hand.
Okay, so here we have soft tissue thickening surrounding the second MTP joint. Not a lot of edema, I think, on the pretty. Well, maybe there's a lot of edema.
Well, this is T1 and this is the stir.
The stir, yeah.
So okay.
Yeah, the joint space doesn't look
too
bad.
bad, but what about all the soft tissues? There's kind of normal soft tissues on these digits. And then you've got the second digit. Look at the soft tissue here.
Right. Yeah, so circumferential soft tissue thickening.
And it's involving one ray.
So could this be dactylitis with psoriatic?
So this is psoriatic dactylitis.
Yeah.
Pretty characteristic of psoriatic arthritis.
Okay.
Right.
I would still bet on this being a female.
Yeah, it's much more common in females. That's correct. Okay, Robert.
All right, so we have a 59-year-old female with pain and swelling of the second toe. It does look like there's some soft tissue swelling about that second digit. and
Yeah.
edema.
Right. And then this was another, it's also called a sausage digit, another case of psoriatic arthritis.
Can you go back one, John? What's interesting about this, um, I need a AP cut. Yeah, no, not this one. We already gone over this one. The next one, John. This one here. What's interesting is the big difference between the metatarsal phalangeal joint of the first toe. You don't have a hallux valgus, and she's 59 years old, so she's been wearing shoes like that would be normal, which is unusual, isn't it?
Yeah.
In what we see in our lectures.
Okay.
All right, so we have a lot of edema in the posterior and inferior calcaneus, and some cystic changes, maybe some erosions at the insertion of the Achilles
Right.
tendon.
So we're dealing with this something that has a lot of enthesitis. We see it here at the Achilles insertion. We also see it at the origin of the plantar fascia here with a lot of bone edema there. And you can see some hypertrophic bone formation here, a little bit of fluid in the bursa, a little Haglund deformity. Okay. The patient also has back pain.
Uh,
So patient has back pain, and we can see a lot of enthesitis here. So this is, it could be rheumatoid arthritis, but there are other things that are more commonly or primarily associated with the insertion of tendons and ligaments like this. And if we look here, this patient had back pain, and I keep coming back to back pain, and then we can see that they're also
yeah,
a disease that causes fusions of the bones.
yeah, well, the SI joints fuse on that,
And this is
yeah,
ankylosing
okay.
spondylitis. And
Yeah, I was gonna look. I was gonna ask for side joints.
Yeah, I think it was
Yeah.
fused on those images.
go back here. Oops. Oops. Yeah,
Yeah,
we fused
okay.
here and here.
Yeah, they're fused,
Yeah. So
and
this
it's
is,
only 23 years old.
Yeah.
yeah. So I think we've talked about this, but we're going to have a lecture later on inflammatory disease of the lumbar spine, where I'll talk in much more detail about the pathophysiology of ankylosing spondylitis. And a lot of the literature in the past is very misleading, like it was for rheumatoid arthritis. A lot of the criteria for making the diagnosis, like rheumatoid arthritis, is really associated more with x-ray findings and with clinical findings of late disease. And of course, late disease, just like rheumatoid arthritis, once you get to this stage, there's not much you can do about it. If you diagnose it very early on, you can stop it now with the same drugs, the TNF alpha inhibitors. So, and ankylosing spondylitis of the lumbar spine is one of the more frequently, early ankylosing spondylitis is one of the more frequent diagnoses missed by radiologists. And it's very important because it typically presents not in the 20s and 30s, like in a lot of the literature before. In fact, a lot of the literature should be someone under the age of 45. It almost always presents in teenage years. And that's when it has to be treated because by 20, you usually have irreversible changes. So it's a kind of, so it's when you ever see, especially a male, coming in with severe back pain and an MR examination, the first thing you should think about is ankylosing spondylitis because that's when it has to be made. And we'll talk about the characteristic early findings on an MR when we get to it. But that has to be treated immediately and not waited on. Okay.
Okay, diagnosis, please. Okay, some erosive change at medial aspect of the first MTP and the IP joint as well, soft tissue thickening. I would think gout from this
Yeah,
picture.
see all these erosive changes, slow and soft tissue thickening. Here's what it looks like on an MR examination. Very characteristic of gout. These are, and we'll talk about gout. We'll have a lecture about the pathophysiology, and I'll show the crystals and how they create inflammatory disease in a future lecture. And here, these typical. This is really diagnostic of gout. These sharp spicules on the edges of the erosions. With rheumatoid arthritis, the edges are always rounded off, and gout, you get these sharp spicules of bone, which are pretty much diagnostic of gout. Robert.
All right, so here looking at that first interphalangeal joint, there's a lot of erosive change in soft tissue there, so can I be concerned for gout?
Yeah, and again, here is nice sharp thing here, a little sharp thing there, and all this soft tissue, right?
Okay, that's a common area of gout, but what would you do if you saw a patient like that? And let's say you're an orthopedic surgeon and an internist sends it to you, or a family doctor. What would he have done before he sent the patient to you if he's a good doctor?
It's a good
Uric
question.
acid test.
You mean blood work?
Yep. So we usually can get patients from either patients or from family docs, and usually you already have the diagnosis of gout, so that shouldn't be any mystery when you find something like this on MRI.
Yeah, very often with MR though, we don't have the diagnosis, and
My brother had gout of the ankle, and
yeah,
so I kind of read up on it a little bit.
yep.
And my uric acid was high too, and I went on the allopurinol.
Yep. Okay. Whose turn is it?
It's me.
Okay.
A lot of edema in the soft tissues and the metacarpal head. I think there might be an erosion at the medial side of the first metacarpal head. Pretty sharply marginated.
Yeah, and you see all this bone edema, and this doesn't have the big erosions, but this was also gout.
Uh, if there are no erosions, probably early case, right, John?
Yes, probably earlier anyway. That's right. Yeah, and if they're not bone erosions, then it's probably mostly reversible disease.
Okay, 61, palpable mass. Yeah, head of the first metatarsal. Yeah, we see a mass.
You know, these are low field scanners.
Yeah,
Here we can see that
you
really marked destruction of that first metatarsal head. Here's what the x-rays look like.
Yeah, erosive change with these sharp margins, I would think gout again.
So I'd certainly think gout with that. Looking at the bone here, the other thing you always have to think about in a situation like this would be infection.
Okay.
Osteomyelitis can produce synovial thickening and destruction of the bones here as well. But with this, you're not going to see this kind of spiculed bone and an osteomyelitis, and you shouldn't see multiple locations of disease. So again, this is characteristic of gout. And some people tout dual energy CT looking at this because uric acid and calcium absorb different frequencies of energy, so you can differentiate the two if you do CT with two different energies. And here's a case where we could see that all this soft tissue thickening and pain. And then if you do a CT scan, you could color code uric acid versus calcium, and you can see the uric acid deposits, which helps nail down the diagnosis of gout. Most studies have found that that you do not need dual energy CT to make the diagnosis in the vast majority of cases, but it may be helpful occasionally if there's some clinical concern. Or so just remember that dual energy CT scan may be valuable in this setting. Okay, Robert.
All right, so looking at the ankle here. Yeah, oh yeah, looks like there's some soft tissue there. Yeah, again, anterior lateral aspect of the ankle looks like there's some heterogeneously enhancing soft tissue there. So, and anterior looks like there's a lot of soft tissue there. So again, I'd be concerned for gout.
Right, good. And that's all gout, tophus formation.
One thing about these is when you examine the patient, these areas are very tender. So, and one thing about gout also is that it comes and goes, depending on whatever nutrition you have. I think that's probably an important aspect of gout.
Good. Thank you, John. Now the patient came in with ankle pain.
Okay, so it looks like synovitis, flexor hallucis longus, and flexor digitorum longus. A lot of debris in the tendon sheath
Notice
there.
how low signal that is on the T2 weighted image.
Yeah.
A lot of debris in there, so it looks like a synovitis. If we go to the coronal images,
Yeah, these some low signal
like a bunch
heterogeneous
of big beads
masses, yeah.
going down along the tendon sheath. And that's very characteristic of gouty tendinopathy. You can have marked thickening of the tendon itself, or you can have marked thickening of the sheath, or both, due to gouty tendinopathy.
Okay, chronic painful Achilles mass surrounding the Achilles tendon. We see this lobular soft tissue mass on either side. Yeah, with significant enhancement. Could this be this gouty tendinopathy again?
Yeah. Gouty tendinopathy. Robert?
All right, so we have a 39-year-old with insertional pain, and again, looking at that distal Achilles tendon, there's some intermediate signal there. Again, I'd be concerned for gouty tendinopathy. It doesn't look just like normal.
This is very inhomogeneous, and then you also have a lot of insertional osteitis here in this area as well, which is both in this. Notice how sharply defined this is. Most inflammatory conditions have very inhomogeneous or very indistinct margins. Gout tends to be very sharply defined, which we see there, and that's gouty tendinopathy, and that's what it looks like within the tendon, which is not an uncommon finding.
Most of these are treated by rheumatologists, and orthopods don't get involved unless a tear occurs or dislocation.
Thanks, John.
Okay, hot swollen ankle. So it looks like there's some soft tissue edema and irregularity over the lateral malleolus. Yeah, is that within the bone, distal tibia?
Right?
Yeah, effusion.
Big effusion. Sinus tarsi is abnormal.
Yeah.
Along the left field scanner, a lot of synovial thickening, synovitis. And this was aspirated It could be rheumatoid arthritis, could be gout. This turned out to be pseudogout.
Okay.
Calcium versus uric acid.
Okay, 24-year-old male. Yeah, the distal tibia and fibula have this periosteal thickening that's irregular. The hands, yeah, similarly with the proximal phalanges, they look very thickened.
Yeah, it's very thickened. The skin is kind of thickened as well, and this is pachydermoperiostosis.
Okay.
It's often seen in primary hypertrophic osteoarthropathy, highly associated with cardiac disease or cancer and lung disease. But there is a congenital form due to a gene mutation.
Usually the distal phalanges, distal phalangeal joints are thickened. And that's one.
Okay, good. Roberts, 15-year-old surfer with foot pain and hand numbness.
All right.
This is one of our former fellows here a number of years ago who was an avid surfer.
Okay. Well, it looks like there's increased signal within the proximal phalanges, and that's really the only thing that stands out. But trying to piece that together with the history and
So this
whatnot.
patient had Raynaud's phenomenon. And for people who have Raynaud's, you get hyperactive vessels that constrict when it gets cold, and they get pain in the distal extremities. So a lot of people have trouble skiing and going to cold area. This guy liked surfing so much that even though he had Raynaud's, he just continued to surf. And what he's starting to get are ischemic changes within the bone and the soft tissues of the extremities. And it could cause resorption of the bone, and you get marked thinning of the soft tissues as well. So, and it's painful, but
Well, they wear
surfing is more important
wetsuits.
for them.
It'd be worse if they didn't wear wetsuits.
Yeah, right. Yeah, but he should probably wear booties as well.
Yeah.
Okay, that's
Could
the
be
end.
that is a smoker too.
Could be, but a 15-year-old surfer may not be a smoker, but possible. It would make it worse. Okay, well, that's the end of our foot and ankle lectures. So we'll start a new topic tomorrow. Thanks, everyone.
Have a good afternoon, everybody.
Thanks, John.
What's your topic tomorrow, John?
I don't know. I'll have to figure that out. I'll let you know.
Okay.